Hello there, I'm Michaela Geiger. I'm one of the Postmasters Adult Gerontology Acute Care Nurse Practitioner students, and I'm here today to share a case study with you all. So the patient that I'm presenting today is a patient that had a complaint of abdominal pain with nausea and vomiting. Coincidentally, this patient was a 78-year-old male at an outpatient cardiology office visit, was found to have an abnormal EKG that revealed sinus rhythm with an inferior infarct pattern, along with some nonspecific ST abnormalities. His associated symptoms were abdominal pain, nausea, and vomiting for the past 4 to 5 days. The abdominal pain is located in his right upper quadrant with radiation to the mid-epigastric area. His pain was variable, 5 to 8 out of 10 on the pain scale, with intermittent episodes lasting 3 to 5 minutes. His symptoms occasionally were aggravated with movement. There were no alleviating factors. He had tried over-the-counter acetaminophen and ibuprofen without any relief. The patient was advised to come to the ER for further evaluation of his symptoms and abnormal EKG. On arrival to the emergency room, patient did not have complaints of chest pain, but he did have complaints of some intermittent nausea and vomiting. He was admitted by cardiology service for further evaluation and management. His physical exam revealed he was alert and oriented. He was in no acute distress. His heart rhythm was normal S1 and S2. He was a little tachycardic. His abdomen was soft without any significant tenderness or guarding. He did have some bowel sounds present. Overall, the symptoms that he was experiencing did relate to the possibility of him having an MI or an acute syndrome, coronary syndrome, that is. The rest of the systems were reviewed and were negative. So in the ER, he had an EKG. It revealed a normal sinus rhythm with an inferior infarct pattern with nonspecific ST abnormality. His elevated high sensitivity troponin, it was 28 with a 2-hour delta pending, and his pro-BNP was elevated at 1,471. He had an elevated serum creatinine of 1.8 and an elevated blood glucose of 347. A CT of the abdomen and pelvis was obtained, which was concerning for acute cholecystitis, probable reactive inflammation of the stomach, proximal duodenum, and colonic hepatic flexure. He also had an ultrasound of the gallbladder, which revealed gallbladder distension or gallbladder wall thickening, concerning for acute cholecystitis. He had an echo, which revealed a LVEF of 51 to 55%, grade 1 diastolic dysfunction with some trace mitral regurgitation. His vital signs were stable: blood pressure 164/84, heart rate 107, temp 98.3, breathing 27 times per minute, and his O2 was 95% on room air. During his admission, critical care medicine was consulted for concern for cardiogenic shock versus sepsis versus volume depletion. Patient became very hypotensive in the ER after about 40 minutes, where his vitals were repeated, and he was temp of 98.3, blood pressure 93/63, heart rate 92, respiratory status breathing 31 times a minute, and his O2 was 93% on room air. General surgery was also consulted for acute cholecystitis. Differential diagnosis: acute coronary syndrome, possibly an NSTEMI, cholecystitis versus viral gastroenteritis. Clinical impression: abdominal pain with associated nausea and vomiting versus acute cholecystitis. Hypotension versus sepsis versus cardiogenic shock. Patient was transferred to ICU. He had acute kidney injury with a serum creatinine of 1.8, likely secondary to volume depletion. He was resuscitated with IV fluids. Had some leukocytosis. His WBC was 12.9 upon arrival to the ED, had some transaminitis with an AST of 964, an ALT of 733, and an ELK phos of 160. He ended up having some elevated troponins where his high sensitive troponin was 18 to 28 to 31 to 32. Coronary artery disease, status post 4-vessel cabbage in the past, Lima to the diag, SVG to the LAD, SVG to the OM, and SVG to the RCA on April 18th of 2019. Hypertension with associated type 2 diabetes. His blood pressure was controlled. Hyperlipidemia with associated type 2 diabetes, and of course, type 2 diabetes. His past medical history included coronary artery disease, status post 4-vessel cabbage, hypertension, hyperlipidemia, and type 2 diabetes. He had no known drug allergies. Surgical history was his 4-vessel cabbage in 2019. He had a decubitus ulcer excision in 2021, a prostate biopsy in November of 2021, and a colonoscopy with biopsy. His social history, he was a former tobacco use, quit in 1996. He denied ETOH use and no history of illicit substance abuse. Family history, his father had a history of hypertension and a stroke. His mother had no significant history, no siblings, unknown grandparents' history. Cultural considerations, good family support throughout his admission. Family was updated on patient's condition at his request. All questions answered. Patient and family verbalized a good understanding of the information they received. His procedures, diagnostics, and labs. Of course, we talked about his CT of the abdomen and pelvis, which was concerning for acute cholecystitis. He had the ultrasound of the gallbladder, which also had concern for acute cholecystitis. He had his echocardiogram, labs, which included the CBC, CMP, MAG, lipid profile, renal function panel, and a hemoglobin A1C. He did undergo a left heart cath during this admission. He had successful PCI of the SVG to the LAD with a drug-eluting stent. General surgery evaluated and no plans for emergent cholecystectomy at this time. Based on the American Heart Association guidelines, use of DAP for patients after PCI, of course, you wanted to use dual antiplatelet therapy for a minimum of 1 year. Here's also some traditional and non-traditional risk factors for cardiovascular disease. And as future recommendations, of course, we want to consider risk factor modifications to include diet, exercise, medical, and medication compliance. Continue goal-directed medical therapy, which included aspirin 81 milligrams daily, Plavix 75 milligrams daily, low pressor 25 milligrams twice a day, Imdur 30 milligrams daily, Zetia 10 milligrams nightly. We're going to add atorvastatin 80 milligrams nightly, outpatient after we repeat his hepatic function panel and when his LFTs are within normal range. He's going to continue his home diabetes medication, which included Actos 30 milligrams daily and metformin ER 500 milligrams daily. We are going to provide him with information and get him scheduled for cardiac rehabilitation, follow up with cardiology within 1 week post-discharge, and follow up with PCP within 2 weeks or sooner if medical condition declines or nausea and vomiting has not improved. And here are the references that I used for this presentation, which included the American Heart Association, our Washington Manual for Cardiology Subspecialty, and of course, our current medical diagnosis and treatment 2023. Thank you so much. It was a pleasure speaking with you all, and I hope you enjoyed this presentation.